Can everybody hear me?
Yes.
Great, thank you. Um, I might start the webinar now. Hello, everyone. I'm Catherine Bloom, the ADDC Executive Officer, and I'd like you to welcome you to this seminar on advancing health equity for persons with disabilities. But before we start, I'd like to do an acknowledgement of country. We acknowledge the traditional owners of the country throughout Australia and those lands from which we are all joining. We acknowledge their continuing resilience, contributions, connection to the land, culture and water, and pay respects to their elders past, present and emerging. Before we get into it fully, just some housekeeping, some accessibility measures. We sent out the captioning link in the reminder email about an hour ago, so you should have that if you need it. And Mel is also going to put that in the chat, so you can access it there. And if there's any other issues with accessibility, if you could put that in the chat, that would be great, and Mel can assist. So the format of this session is we've got some fantastic panelists, and we're going to the there's a URL about for the captioning too. Some great panelists who are going to speak, and then at the end of the session we're going to have a question and answer session. So if you've got any questions whilst people are presenting, if you could put those in the chat, and we'll come back to them, or at the end of the panelist session, put the questions in the chat, and we can come back to them then. So I'm just going to introduce the topic. We're going to be talking about the WHO Health Equity Initiative and the WHO Health Equity Network. But first, the Disability Health Equity Initiative. And I just wanted to set. Oh, thank you. I'm just getting some feedback apparently. Um, don't know what would be causing that. Is it significant, the feedback, Mel?
Not,
Okay.
it's working well from this
Okay.
end.
I'll keep going then.
Yes.
Um, all right. I was introducing the WHO Disability Health Equity Initiative and setting the scene for why it's necessary. As we know, there are 1.3 million people in the world that have a disability, and this number is projected to grow. Persons with disabilities are among the most marginalised populations globally and experience a range of health inequities, including earlier deaths, up to 20 years less earlier than people without disabilities, and there's a higher risk of disease. These health inequities arise from unfair and unavoidable conditions within and beyond the health system. So the right to the highest attainable standard of health for everyone is a state obligation, and the health sector must act to ensure that health inequities that undermine the fulfilment of this right for people with disabilities are addressed. So there have been different global efforts over the last 15 years to advance health equity for persons with disabilities. And this has contributed to the need for the for the Health Equity Initiative. This began first with the World Report on Disability, which was produced by the WHO and the World Bank in 2011. And then more recently, there was the World Health Assembly landmark resolution on the highest attainable standard of health for persons with disability, which aims to address to advance the agenda of disability inclusion. Flowing from this, the WHO published the 2022 Global Report on Health Equity for Persons with Disabilities. And this in turn flowed on to the establishment of the WHO Disability Health Equity Initiative, which is to address the need and to continue creating momentum and to galvanise unified and joint action between disability and health sectors to advance health equity for persons with disabilities. This is actually the second session that ADDC and WHO has held on the Health Equity Initiative. The first was in 2025, and this focused on the WHO tools, particularly the Disability Health Equity Guide for Action, which provides practical guidance on the process that ministries of health should lead on to integrate disability inclusion into health system governance, planning and monitoring processes. And that was published in November 2024. And the Disability Health Equity Guide for Action has been implemented in several countries, notably Malaysia, the Philippines, and Cambodia. This session is going to focus more on the policy and systems level preparation which governments have undertaken, which underpins the Disability Health Equity Initiative. So we're going to have three speakers, Jody Mills from the WHO Western Pacific region, who will update us on the developments in the Health Equity Initiative. And Dr. Noor Bazoura Binti Abdul Hamid will talk to the policy and systems level preparation in Malaysia. And lastly, we'll have Dr. Pratima Gajraj Singh, who will present on the barriers to health equity for people with disabilities and the policy response in Fiji. But if we can go back a few slides, actually, Mel, we'll go back to the first slide that introduces the next one. Now we're going to talk about the network as opposed to the initiative. And the WHO Health Equity Network is a WHO hosted network of stakeholders whose mission it is to support the Disability Health Equity Initiative through coordinated advocacy and united action towards health equity for persons with disabilities. And as I understand it, there are 71 civil society organisations that have joined the network, and the inaugural meeting was on the 12th of November last year. There are three main objectives of the Health Equity Network. The first is to convey a common understanding and narrative of evidence-based changes which are required to achieve the highest attainable standard of health for persons with disabilities. The second is to conduct evidence-based advocacy that increases awareness on health inequities experienced by persons with disabilities and on actions needed to address them. And the third is to enhance dialogue, knowledge sharing and connections as appropriate among network members for action towards health equity for persons with disabilities. Next slide, please. There are several good reasons to join the network for organisations. It's an opportunity for organisations to influence and advocate. They can co-develop health equity and disability advocacy messages and activities with other organisations that promote and support the health equity streams and activities. Another is to connect and share and learn. Organisations can connect and collaborate with other members who work in health equity and disability and share knowledge and experience with each other. And also it's an opportunity to be recognised. Organisations will receive recognition of your contribution from the WHO. And it will increase the visibility of your organisation and widen the scope and influence of the work of your organisation. And it's also a benefit for other networks and partnerships. It identifies potential areas of collaboration between your work and other members and sectors. Next slide, please. And the criteria for acceptance to the network is summarised there. It's an opportunity, it's that organisations need to contribute significantly to the advancement of health equity and or public health. And organisations must be working internationally with proven experience and expertise in the subject matter for at least 3 years. And organisations must have an established structure, constitutive act and accountability mechanism. There are 4 different work streams. The first is one that builds leadership on health equity amongst persons with disabilities. And this work stream is intended to strengthen leadership and advocacy capacities among persons with disabilities and their representative organisations in the area of health equity. And the second work stream is one that ADDC has joined, and though we're not that active at the moment, we're endeavouring to be more active. But this work stream is a focus on advocacy, elevating health equity for persons with disability as a political priority in health. This workstream aims to elevate the political prioritisation of health equity for persons with disabilities within the global health sector. The third workstream is aiming to create a disability inclusive health sector, and it will focus on integrating disability inclusion, international health systems strengthening reforms by engaging national policymakers in advancing the inclusion of persons with disabilities within health systems. And the fourth work stream is to establish robust indicators, evidence and monitoring, and it will work towards influencing member states to adopt global indicators on health equity for persons with disability, adopt better data quality on disability at country level, and seek more funding for implementation research. Um, I just had one example of what one of the work streams is doing, which is work stream two. It's looking at elevating the profile of disability health equity at a global level through targeting some high level fora. Um, at either organised sessions on the topic or they bring in self-advocates with a disability to speak at events. For example, at the WHO World Health Summit in Kenya and recently at COSP in New York. Um, I'd like to now move to introduce Jody Mills, who's the technical officer within the Policy and Service Design Unit of the WHO Western Pacific Regional Office. She's responsible for the areas of rehabilitation, assistive technology, disability, and long-term care. And Jody has a Bachelor in Occupational Therapy, a Master's in International Public Health, and a doctorate from the Faculty of Medicine and Health at the University of Sydney. And Jody's going to be updating us on what's been happening with the initiative.
Thanks so much, Catherine. Is it over to me now?
Yes.
Great. All right. Good morning or good afternoon, everyone, depending on where you are joining from. It's a pleasure to be with you today. And thank you, Catherine and ADDC colleagues, for the opportunity to partner together again for the seminar and share some of the work that's been happening with this network and initiative and with the global momentum that is building for disability health equity within the region. I've got a few slides that I'll bring up. Bear with me one second. And I just want to make sure that you all see the correct version. You're not seeing the notes pages, I hope. Just let me know if you are, and I'll switch views. But yes, as Catherine said, I'm part of the team in the WHO Western Pacific region, which is based in Manila. But as you would have gathered from my bio, I am Australian and spent many years working in the Australian health system. Disability is one of the key areas of my portfolio. That said, what we really promote within the Western Pacific region and across all the regions actually is that disability is really owned across the organization and across the different programmatic areas. So part of my role is really promoting that as well. And that is something we are trying to sort of advocate more widely across the global health sector in general. So today I just want to share a little bit about just this theme of collaboration, which is really at the heart of the Global Disability Health Equity Network and Initiative, and just highlight exactly why this is so critical in general and particularly at this time. And then I will tell you a little bit more about the network in terms of some of the concrete activity that's happening and some of the future directions or key things that we really see are needed. I'll share a link at the end with access to some of the resources that WHO are also developing and using in countries across the region and the world as well. So just wanted to speak a little bit about collaboration as a real catalyst for disability health equity. This is something that we have observed in different networks within the organization or that the organization is involved in. And we really recognized that there was a need for a network within the disability health equity space. There is incredible expertise and great sort of work being done by partners working in disability around the world, and bringing them all together really presented an exciting opportunity to advance this particular agenda. One of the reasons why collaboration is particularly important is because the drivers between the health equity, the health inequities that we see amongst persons with disabilities are incredibly broad. They span different sectors, different stakeholders, and really addressing these inequities in a meaningful way is not something that can be done by any one particular group. It really does require very broad action across multiple different stakeholders. And in order to sort of get this moving in the right direction, we need to be coming together and collaborating. So just to highlight, for example, the drivers between health inequities that we see, and this is really elaborated quite well in the WHO Global Report on Health Equity for Persons with Disabilities. These drivers span clinical, social, economic, environmental, and attitudinal domains. So there's no one sector or discipline that really holds the levers to address them all. For example, inaccessible healthcare systems, physical, communicative, attitudinal barriers within services and systems interact with these, what we could call upstream social determinants, such as poverty, unemployment, housing insecurity, social isolation, and they all compound to result in some disadvantage across the life course. So it is a complex and multifactorial picture, even just thinking about, what many of us would observe in barriers to healthcare, from transport, poverty, the policies and processes, education and employment, and so on. So really action is needed across a wide number of different stakeholders, and we need to all be pulling in the same direction. The network is one avenue through which these stakeholders can come together and I guess combine their powers towards shared common objectives and priority areas for action. So in terms of the collaboration potential, what we see is that collaboration really builds what we can refer to as the critical mass that is needed for really effective advocacy. So, you know, each of these different organizations might be doing incredible work, but the numbers can sometimes be a little bit limited. When everybody is coming together, the number and the noise really amplifies, and you start getting the same messages repeated sort of across countries, across the world, across different sectors. And this really is what drives home key messages and gets people really understanding and drawing visibility to what's needed. Collaboration is also needed not only among disability actors across different sectors, but between disability actors and mainstream health development initiatives. So we don't want to just be working within a bubble. We want to be collaborating in a broad way that really brings in people that are working, for example, on vaccines, on maternal and child health, on cancer care, on rehabilitation, on palliative care, that we need to be making sure that we are working together to make sure that all of these mainstream development initiatives are really focusing or considering deeply how disability inclusion is factored in and designed into the work that is being done there. We also see that cross-sector collaboration creates these conditions for co-designing innovative service models that neither health nor disability systems would really develop independently. So it just creates a really nice environment for growth and development and innovation. This is an opportunity we don't want to miss, particularly considering evolutions that we're seeing in digital health and digital technology more broadly. Just looking at collaboration in the context of the WHO Health Equity Network, I just wanted to highlight a few examples of the action that is happening through the network to give you a sort of concrete picture of what's going on. And this by no means captures the breadth or the scope of work that's been done by the network, but it does give you a sense of what kind of things can be done. And of course, the network is still very new, actually. And so it's quite amazing to see what's already been done to date. So we're seeing some quite targeted high-level forums and sort of been hosting disability inclusion topics and self-advocates with are being brought in to speak at various different events that are not necessarily specific to disability. So it's that cross-pollination sort of opportunity that's been harnessed there, and really trying to bring visibility to disability inclusion at very high level events. There's a Lancet Commission on Health Equity for Persons with Disability. So this is a special issue on disability and health, and a really great opportunity to start to actually stimulate more research and bring visibility and provide a platform for the great evidence that is being generated around disability health equity. So that's a really exciting opportunity that's emerged. There's also support to countries for disability inclusive interventions. For example, in Ghana, they're looking at supporting them to embed a disability identifier within their health information system so that the country will be able to have a better picture of how people with disability are accessing and using health services, for example. And this is really great in terms of guiding, planning, and service development. There's also work being done to develop shared communication tools on OPD leadership in health equity. So really trying to promote and empower the role of organizations of persons with disabilities in decision making and in action as well. So just a few sort of concrete examples there, but as I said, this isn't. There's many other things happening as well. Quite recently, all of the different work streams were finalising their work plans. And I'm not sure whether those are going to be made publicly available or not, but if you do have a particular interest in what a work stream is doing, please feel free to reach out and I can share that information with you. In terms of building global momentum, so I've talked already about leveraging collaborations and networks, and the real potential there is to build that critical mass, to cross-pollinate across sectors, and also, I guess, to say what I didn't mention before was how important this is at the moment in the current economical environment. We are really, really sensing, that there is a little bit of a shrinking funding pool for health in general, but we're experiencing this in disability as well. So we really must be coming together and leveraging the expertise and influence of various different parties to see action still occurring. And this is we're seeing really promising results from these initiatives. And I think, although we hope that the funding will increase over time, there has actually been a really nice sort of prompt to really scale up the level of collaboration and partnership that we have with other organizations. So in terms of building global momentum, collaboration and networks really, really important, play a critical role in this. The other part of building global momentum is really making sure that people know that this is everybody's business and building accountability for disability inclusion across different mainstream health initiatives. For example, including disability-related indicators and requiring reporting on disability health equity within various different projects is one example of how we can be moving this forward. So that, again, as I said before, it isn't just people working on disability-specific programs and projects that are concentrating on disability inclusion, but that projects that are working on, I mentioned before, whether it's cancer care or vaccines, are also really making sure and being held accountable for making their programs disability inclusive. We also want to make sure that we are really measuring and having data to support disability health equity. So disaggregating data for disability is a really important part of this, but also really providing platforms and drawing attention to the data that is becoming available. This is needed kind of at the program level, but also at sort of national and global levels more broadly as well. Moving forward, the WHO Global Report on Health Equity for Persons with Disabilities posed some really strong recommendations about how we need to be moving forward to address the quite alarming inequities that were reported. What we see now is the need and an appetite from countries for really concrete and operational resources and tools and examples from countries that contextualize how to really operationalize these recommendations in practice. So this is sort of what we are wanting to work on, amongst other things, in the coming months and years as well. And there's an invitation here really to share the work that you're doing and to provide case studies and the learnings that you are gathering through your various different fields of work. Just to share a little practical example of this from within the Western Pacific region, we were invited by the Ministry of Health in Brunei to work with them on making their NCD services more disability inclusive, particularly their programs around obesity. Of course, we have tools and approaches for making health services more disability inclusive, and those are going to be very relevant and useful in this context. But what would be even nicer is if we had specific examples from other countries within the region and beyond, highlighting the different strategies and approaches that have been done within NCDs, specifically, for example. So we're really looking forward to start to kind of knuckle into some of that more concrete, practical type of guidance and advice as well. I think that these slides were probably shared, so I hope that you'll be able to just use this QR code to access some of the WHO resources on disability health equity, the global report, the guide for action, more information about the network, as well as various tools for data collection as well. You can also access these quite easily by just Googling WHO's disability page and navigating within that. So I'll wrap up there. Thanks very much, Catherine. Back over to you.
Thanks, Jody. We'll definitely share the slides when we share the recording. And thanks very much for bringing the power of collaboration to life and sharing those concrete examples. And now we'll move to our next speaker, who's Dr. Pratama Garaj Singh. Pratama is a senior rehabilitation physician and is nationally recognised leader in disability inclusive health and rehabilitation services in Fiji. She has over 2 decades of experience and has played a pivotal role in advancing rehabilitation care, strengthening health systems, and improving access to services for persons with disabilities across the Pacific. She's in the Ministry of Health and Medical Services in Fiji, and she has led in that role major national initiatives, including the development of Fiji's Disability Inclusive Health and Rehabilitation Action Plan 2023 to 2027, which is now the guiding framework for rehabilitation service delivery in Fiji. She's currently leading transformative projects such as the establishment of Fiji's first National Rehabilitation Centre and a multi-year assistive technology program supporting school-aged children. So I'll hand to Dr. Pratama now, who will be speaking on the barriers to health equity in Fiji for persons with disabilities and the policy response and how to operationalise health equity. Thank you, Pratama.
Thank you. Melinda, can you please share the presentation? Good afternoon, everyone. In Fiji, we are approaching almost 1:30 p.m. So, Bula, and thank you for joining. I'll speak on the Fiji's initiative towards, strengthening disability inclusion in health in Fiji. She'll change, yeah. So, what is the current situation in Fiji? The data on disability in Fiji, according to the 2017 Fiji National Census, 13.7% of Fiji's population aged 3 and above reported at least one functional difficulty or disability, and that accounts to roughly 113,595 persons. Now, a more recent survey data estimates that 8.8% of children aged 2 to 17 years have functioning difficulties in at least one domain. Next slide, Melinda, please. Yeah. So, what are the barriers for persons accessing services within Fiji's Ministry of Health structure? So, there is structural and social determinants. Poverty. We know minimum 35% of Fiji's population is living under poverty, and there's inadequate access to assistive products all over Fiji. There's physical and infrastructure barriers. There's inadequate public transport access to wheelchair users. Basically, very few privately owned vehicles are accessible to wheelchairs. The rest of the public transportation system is absolutely not supportive of persons who are wheelchair users. There's financial barriers. There's a lot of out-of-pocket costs for care, travel, assistive devices, and caregiver support. Disability allowances from government are often insufficient. It's grossly insufficient to support persons living with disabilities in the community. So added expenses, accessing health services in Fiji is something that is very difficult for the families to accommodate. There's communication and information barriers. So there is limited availability of sign language interpreters in Fiji. Only the main referral hospital in Suva has sign language interpreters, and they are funded by external organization, not under Ministry of Health's funding. And then there is inaccessible reading materials that can be used by persons accessing services at our health facilities. So that affects persons, with the visual impairment accessing our services as well. Next slide. There are attitudinal and cultural barriers. There's stigma, there's negative societal attitudes and cultural beliefs. It's very common still in Fiji. This discourages persons with disabilities and their families from seeking healthcare. There's health workforce limitations. Many health providers lack training in disability inclusive care, and they may not know how to adapt services or communicate effectively with patients with disabilities. There is limited access to sexual and reproductive health. Our women and young people with disabilities often do not receive full range of sexual and reproductive health services, and accessible information for them is scarce. There's data limitations. There's insufficient disability disaggregated data. This hampers planning, monitoring, and evaluation of health services for persons with disabilities. The data that we collect at the rehabilitation department is often used as the national data for Ministry of Health and Medical Services here. However, this does not reflect the accurate national data, as we do not capture all the persons during our outreach programs. To address these barriers, Fiji's Ministry of Health and Medical Services has identified increased decentralization of health services. This includes, in particular, maternal, mental, and rehabilitation services as a strategic priority to allow for broader distribution across the community and ensure better access. So what is Fiji's response so far? So Cabinet endorsed National Disability Inclusive Health and Rehabilitation Action Plan 2023 to 2027 on the 14th of March 2023. And this action plan was successfully launched on the 27th of September 2023. The government is also increasingly collaborating with disability-led organizations such as National Council for Persons with Disabilities, Fiji Disabled People's Federation, the organization that represents people living with disabilities, and Frank Hilton Organization, the organization that works specifically for children living with disabilities, and international partners to expand access across all ages. Next slide. The national commitments to health equity for persons with disabilities. Now I'll briefly talk about the National Disability Inclusive Health and Rehabilitation Action Plan 2023 to 2027. This action plan has 2 goals and 4 objectives. The 2 goals are, next slide, please. Goal 1 is focused on inclusive health to ensure that children and adults with disabilities have access to inclusive health services at community, primary, secondary, and tertiary levels. Goal 2 is very specific to the rehabilitation needs of the country to help strengthen the Ministry of Health and Medical Service rehabilitation and assistive products workforce, and ensure rehabilitation and assistive product services are available and accessible to all who may benefit. This action plan has 4 objectives. The first objective is to reduce barriers and improve access to healthcare services and programs for all, including persons with disabilities. The second objective is to improve the quality and reach of rehabilitation and assistive product services at all levels of Ministry of Health Service. The third objective is to strengthen disability-specific data and information collection throughout Ministry of Health Information System. And the fourth objective is to increase multi-sectoral collaboration for better coordination and more efficient rehabilitation and disability support services at all levels. Next slide, please. So what is the action to date? Establishment and recruitment of the rehabilitation coordinator role within the Ministry of Health and Medical Service structure. The Action Plan Steering Committee has been formed with multi-sectoral representation, providing governance monitoring and evaluation of the action plan activities. There's dedicated funding under Ministry of Health to implement the action plan. When the action plan was endorsed, we received a funding of 50,000 Fijian dollars to help support additional activities from the action plan. That funding has increased to 56,250 in this financial year. There is Korean government-funded construction and establishment of the National Rehabilitation Center, which is currently underway and it's projected to be completed in August next year. There's 80 scale program. Fiji has secured significant funding for screening and provision of vision, hearing, and mobility assistive products for school-age children. The program is currently in the planning phase, and we are hoping that the implementation phase will start a little bit later this year. Next slide, please. Yeah. So Fiji National Policy on the Rights of Persons with Disabilities 2025 to 2035 was launched on October 2025. This policy commits to mainstreaming disability across health, education, employment, social protection, and infrastructure. Next slide. So how the action plan enables multi-stakeholder coordination. The action plan provides a formal government-endorsed framework that brings together multiple sectors and stakeholders around shared goals for disability-inclusive health. It enables coordination in 4 key ways: shared goals and accountability. The action plan establishes common objectives, indicators, and timelines across health, rehabilitation, disability-led organizations, and international partners, creating a shared accountability framework. There's structured multi-sectoral governance. The plan mandates multi-sectoral participation, grounding coordination in human rights and equity principles, and aligning with national frameworks such as the Fiji Rights of Persons with Disabilities Act 2018, UNCRPD, WHO guidance, and SDGs. Mainstream disability inclusion. By mainstreaming disability in Ministry of Health planning cycle, the plan reduces fragmented, siloed approaches and enables coherent health service delivery from community to tertiary level. Disability leadership and participation. The plan embeds meaningful participation of persons with disabilities and disability-led organizations such as the National Council for Persons with Disabilities, the Fiji Disabled People's Federation, and the Frank Hilton Organization in decision-making, monitoring, and evaluation. Next slide, please. The National Disability Inclusive Health and Rehab Steering Committee. So I briefly talk about the steering committee. The Action Plan Steering Committee is the primary governance mechanism through which the action plan enables sustained multi-stakeholder coordination. So the composition is multi-sectoral. The representation includes various government ministries. So we have Ministry of Health, Ministry of Education, and Ministry of Women, Children, and Social Protection. We also have the National Council for Persons with Disabilities. We have Fiji Disabled People's Federation representing persons living with disabilities. And then we have Frank Hilton Organization that provides specific care to the needs of children living with disabilities. Observers are invited on needs basis. The functions of the committee is to provide governance, oversight, and monitoring and evaluation of the action plan implementation, facilitates information sharing across sectors, and reviews progress against action plan goals and objectives. Then there is this leadership, disability leadership. The committee operationalizes the principles of nothing about us without us by ensuring persons with disabilities and their organizations have a formal voice in governance and decision making. Now, thank you for listening. If you have any questions, you can write and then we can discuss this in our discussion session. Thank you.
Thanks very much, Pratama, for bringing to life how Fiji is operationalising health equity through the action plan and policies. Appreciate it. I'd now like to introduce Dr. Noor Bezura Binti Abdul Hamid, who is the head of Persons with Disability Health Sector in the Ministry of Health, Malaysia. She's a senior public health physician And the OKU health sector under the Ministry of Health of Malaysia provides strategic and technical leadership in developing and implementing disability inclusive health programs. This includes policy formulation, service enhancement, monitoring, collaboration with both local and international stakeholders to ensure accessible and equitable healthcare for people with disability in Malaysia. Basura will be speaking on the policy and systems level preparation that's been made in Malaysia. I'll hand it over to you now.
Hi, everyone. Is my slide? Do I have to share my slide?
I'm not sure who's sharing the slides. Is it you
Yes,
or?
I can share my slide.
Doctor, yes, can you
Yes,
please share?
can you?
Thank you.
Yeah, can you see my slide?
Yes, it's loading.
All right.
Great.
Good morning, everyone. I'm Nobizura binti Abdul Hamid, public health physician, and currently hold the position of head of the disability health sector in Family Health Development Division, Ministry of Health Malaysia. So actually today I am honored to share our roadmap for structural change distilled directly from the 2024 WHO Disability Program experience. So our guiding principles, excuse me, this is, sorry, yeah. I'm so sorry, yeah. Okay, our guiding principle is simple, leaving no one behind. And we are here to fundamentally advance health equity for persons with disabilities across our nation. Okay, let's begin. Before that, I would like to thank the ADDC for inviting me to join this webinar. And we are here actually at 9:44 a.m. in the morning. All right. Okay. This is actually the some of the pictures from our programs. WHO consultants came to Malaysia in two sessions. The first sessions early in the April and the second session in July 2024. And this is the photos of our team, my team, because in Malaysia we have developed two series plan of action for person with disabilities. The first plan of actions was in 1996, where we developed the person with disability program, especially for children with disabilities. And the second plan of action was in 1911 to 2020. And we have a vision during that time is for the equity for person with disabilities. And these are the team that work with me, because at the national level, we have Person with Disability Act 2008. And under this act, we have a Person with Disability Council. And this council is actually under the purview of Ministry of Women, Family and Community Development. And under this act, we have a Person with Disability Council. And under the council, we have 6 small committees looking into the whole spectrum of person with disabilities. We have ministry looking into the transportation, under Ministry of Transportation. We have ministry looking into the job accessibility. We have a ministry looking into the infrastructure and accessibility and education accessibility. And we have registration of person with disabilities. And Ministry of Health looking into the quality of life care for person with disability. And the term is a QLC committee. And during the program, we engage my QLC committee. Basically, they are representing seven non-government organization representing each type of disabilities that we have in Malaysia. Okay. So this initiative is driven by the highest level of national planning. Specifically, during that time is 12 Malaysia Plan and the structural reform of the Health White Paper. And our objective is, our ultimate goal is to achieve the true universal health coverage. And however, we must recognize that UHC remains fundamentally incomplete unless our OKU community enjoys equivalent life functionality and is free from premature mortality. Put simply, we cannot claim universal coverage if we leave anyone behind. Okay. So in 2024, there are two phases. The first visit is to assess. We are using the WHO Disability Guide for Action. We audited primary care, secondary care, and rural frontline access points from the community-based rehabilitation centers to rural clinics like Klinik Desa Kuala Sawah and also the district hospitals like Hospital Rembau. Okay, and the second phases after we have concluded what are the gap in our disability services, not necessarily for health, but for the whole services. The second phase is to develop the action plan and design the action plan for person with disabilities. Okay. Our focus groups with diverse OQ groups, parents and also adolescents reveals the three severe barriers. The first one is communication. Severe barriers isolate the deaf community in standard clinical settings, hindering basic diagnosis and care. Workforce shortages, a critical lack of public sector speech and language therapists creates massive bottlenecks for early childhood interventions, just like Fiji experience. And the last one is environment. Traditional chaotic clinic environments subject neurodivergent individuals to intense sensory overloaded. And the solutions to fix this, we rely on the Quality Life Care Committee, a multi-sectoral powerhouse uniting medical experts, ministries, and organizations of persons with disabilities. That is the committee under Ministry of Health. The small committee under a person with disability councils. Okay, and this is the structural audit, the health system assessment matrix. When we did the audit, we evaluate our entire healthcare ecosystem using the WHO Disability Inclusive Health System Assessment Tools. And the diagnosis, the result shows a clear contrast. While our high-level inclusive health service planning is robust, our critical growth priorities sit at the ground level. The insight, we face gap in workforce competency, in information accessibility, and digital health integrations. And the insight is clear. The strategic planning is excellent, and we must fix our ground level execution and communication infrastructure. So the paradigm shift, to bridge these gaps, we are executing a massive paradigm shift. From the past, we are moving away from treating disability as an isolated medical issues managed through detached, standalone, and impairment-specific programs and we are going to the true systemic inclusion. This means embedded OKU accessibility, representation, and care directly into the foundation DNA of our national healthcare architectures. And this is the 8 pillars that we developed during the action plans uh, visits and apa tu? Uh, discussions. Okay. The pillars of National Health Action Plan for 2026-2030. Uh, the shift is operationalized through our blueprints across four strategy areas. The first one is governance and data, because we are expanding the quality life care mandate to integrate OKU voices directly into health policies and expanding disability disaggregated data in our National Health and Mobility Service. And 1 minute. Accessible environments. We are mandating physical accessibility audits for new buildings, establishing formal sign language interpretation contracts, and launching a centralized public-private NGO health services directory for people and community. We are making OPD partners in disability equality training mandatories in healthcare curriculums and piloting explicit disability inclusion in 5 public wellness hub. For future and innovation, we are securing explicit OQ inclusion in the upcoming 13th Malaysia Plan Health Research Agenda and adopting global WHO ITU standards for telehealth accessibility. So, in conclusion, the final takeaway, I will leave you with the core philosophy driving this transformation. True health equity is not just about building ramps and for wheelchairs. It is about building respect, understanding, and inclusive communication into the very DNA of our healthcare workforce. So, armed with this plan of action, the Ministry of Health, the WHO, and the OQ community are actively forging a healthcare system that is genuinely accessible, inclusive, and equitable for all nations. I think that's all for me.
Thank you very much, Norbazura. Thanks for outlining the comprehensive action that the Malaysian government is taking, and particularly the actions in the action plan. I'd like to open it up to questions now. I can't see any questions in the chat. Has anybody got any questions to put in the chat or to raise their hand? All right, I can't see any questions in the chat, so I'll ask a couple that I prepared earlier. This one's for Jody. I know there are 71 civil society organisations in the initiative. What proportion of those are OPDs, Jody?
Thanks, Catherine. So you have the 71 civil society organisations, 14 are OPDs. None of those OPDs are specifically WIPRO OPDs, but the majority are international that have member organizations within WIPRO. So WIPRO is certainly represented within that pool. For example, Down Syndrome International, International Cerebral Palsy Society, and so on. And I've already had sort of direct dialogues with sort of WIPRO representatives of those network members already. Yeah.
Thanks for that, Jody. I've got a question for Pratima. What do you think the risk factors are that could prevent the success of the action plan, particularly in Fiji or other strategies that governments are putting into place?
Can you repeat your question, Catherine, please?
Sure. Can you think of any risk factors that could prevent the success of, in your case, the action plan in Fiji or in other countries that are implementing WHO health equity tools, etc.?
The risk factors that I can think of now, in terms of working with the health professionals, is just their knowledge about including persons living with disabilities in decision making and targeting program for persons with disabilities. Their knowledge in terms of providing specific healthcare for the needs of these people is very, very, very limited. And that's why we got this action plan. And we have a role of a disability inclusion coordinator, whose role is to just create awareness. And we have also developed IEC materials to create that awareness and health education amongst health professionals. And we already conducting actually national workshops to
Thank you.
sensitize them towards that. So I think that's the biggest gap. And then when we receive new health workers into our workforce, we do realize that their knowledge is so limited that they just don't understand.
To state the obvious, a lot of work still to be done and lots of resourcing required. Yeah. I might start to move to finish up the webinar now, to say thank you to our panelists. That you've been fabulous, and I hope everybody in the audience has learnt as much as I have. It's been great.
Catherine, we do have a few questions from the chat.
Oh, okay.
Yes.
Sorry.
From Zanish
Okay.
and Renata.
Yes. Okay. This is one from Zanish, and anybody who feels that they can volunteer to answer this one. How does cultural competence among healthcare providers contribute to health equity? Is there a volunteer from our panel to answer that one?
Cultural competence among healthcare providers contribute to health equity. Yeah, I think by knowing the cultural, because in Malaysia we have multicultural societies. By knowing, because they have also different practices and different discriminations for the disabilities. So knowing this culture can improve equity means we have to tackle, different culture, different approach so that they also can access to our healthcare systems, for example.
Thank you, Norbazura. I think we've got one last question. Renata has commented, great to see the suggestion that health equity includes respect and dignity as part of the DNA of workforces. Now, we've recently had the 20-year anniversary of the CRPD. How are health practitioners being trained about disability inclusion in GP or nursing curriculum? Is anybody equipped to answer that question?
Yeah. In Ministry of Health, we have disability awareness training modules, and we are implementing all these modules because in Malaysia we have public and private together runs the healthcare systems, public, private, and also we are the private is we don't really have any programs for the private at the moment. We only have programs for our health care facilities, healthcare personnel. However, during the discussions, during the workshop, Dr. Emma, the consultant of WHO's disability programs, suggests that we have to develop a module in the universities. So in the universities, at the moment, I only have approached the colleges. We have 19 colleges that our support staff go to post-basic training. So in these colleges, they are going to make disability awareness training as a compulsory training. So when the support staff completed their post basic training, they were trained to handle to work with person with disabilities. So next year, I would like to implement disability awareness module to the universities. So universities that produce doctors, they were trained to, uh, uh, they were trained to know how to handle all type of disabilities like the blind, the deaf, the physical disabilities, uh, uh, um, uh, all type of disabilities because we would like to make them compulsory curriculum in the university so that when they come up with when they come up become a doctors, uh, they are not necessarily come to public hospitals. So they when they open their own private GPs, they were trained to handle disabilities. That is one of the WHO um, modules for training for disabilities awareness training.
From Fiji's side, Catherine, can I just say I haven't worked with the GPs in Fiji, but for the nursing curriculum, there is compulsory attachment of all the nursing students from year 1 to year 4, rotation to rehabilitation department. And of course, when they come to us, there's a structured program with their workplace assessment and lectures and supervisory components and all that. So that is compulsory here in Fiji for all the nursing students going through training in Fiji.
Thank you both. It's great to have you both here to tell us exactly what's happening in your countries, to give us the practical examples. We really appreciate that. I will wind up the webinar now because I know everybody's pretty busy. All very busy. So again, I thank the panelists for such wonderful presentations. And I have a shameless plug for ADDC, encouraging those people who are on the call who aren't members to join. And there's many benefits of being an ADDC member, getting invitations to webinars such as these, receiving our bulletin, which gives you news and opportunities in the disability and equity sector. And there'll be a link in the email that we send to all the registrants with the PowerPoints and the recording. And we'll also send a link about how you can get more information about joining the network. So look out for that. I'd also like to thank everybody that helped getting this together, particularly Jody, who coordinated it, and to Mel, who's done the tech support and preparation, and to Nari, our captioner. So thank you all. Thanks for everybody for making the time to join. Really appreciate it.
Thank
Right.
you.
Thanks,
See you
everyone.
guys.
Right. Bye.
Thank you. Bye.